Good evening, everyone. Welcome to the series of webinars hosted by Department of Emergency Medicine by Yashoda Group of Hospitals. As well, it was a good start last week. We have come up with the interesting topic this week. That was a bear on my chest. So whenever any age group comes with a chest pain, whether it is a stabbing pain or whether it is a chest discomfort, anything comes to ED, why we not to miss the important diagnosis in the emergency department? As an emergency resident, as well as an emergency physician, of course, we are attending the crash case, but someone comes with you holding his chest or her chest, then you need to attend immediately. That's why we are going to talk over next 20 to 30 minutes or so. Today, we have an eminent emergency medicine faculty here. I welcome Dr. S. Saravana Kumar, who is the consultant and unit head at and as well as the GM at Dr. Mehta Hospital, Chennai. He is well known among the EM fraternity, that is internationally renowned emergency medicine faculty for his skills as well as the amount of work he did in the field of emergency medicine at the time of initiation as well as the development. He was very well known across the globe. Currently, he, as I said, like he's working with Dr. Mehta Hospitals, and I am very happy to welcome you, sir. His area of interest are emergency medicine leadership, team building, as well as the quality development in the emergency department. Currently, he's the General Secretary for Society for Emergency Medicine India, as well as the Overseas Examiner for Royal College of Exams. He's the course director across all the programs across emergency medicine at Mehta Group of Hospitals. And he's one important thing is he's very much renowned for his work in the quality implementation at hospitals with CP, QAH, as well as the NABH and healthcare providers. As well, he's the editor-in-chief for Health Quest, which is a joint venture by SEMI, AHPA, as well as Indian Space Organization guidelines for improving the patient safety in the emergency medicine department across India. And I welcome Dr. T. Srinath Kumar sir also onto the floor. He's organizing, he's the mentor as well as he's the kingpin behind this webinar series for the launch. As well, I welcome the Dr. Naveen Nimala, who is the organizing secretary for this webinar. As well, organizing team, Dr. Ranjith, who is the HOD for emergency medicine at Yashoda Hospitals, Hyderabad, and Dr. Kiran Varma, who is the HOD emergency medicine at Yashoda Hospitals, Malakpet. So over to Dr. S. Saravana sir to start the session. Okay, and please don't leave the session behind, and don't leave for the residents. It's very important for the residents to stay back till the end of the session, because we have an interesting poll to answer, wherein we can see what is your awareness about the chest pain assessment in ED, as well as it will improve your knowledge. Okay, thank you, and over to Dr. S. Saravana. Fine.
Thanks, Suresh. Hope you can hear me.
Yes.
Right, dear friends, very good evening, and it's my pleasure to be here. And first and foremost, thank you, Dr. Srinath, Dr. Naveen, and of course, Dr. Suresh for inviting me over for this wonderful event organized by Yashoda Hospitals. I happened to participate in the last week's quiz, and such a well thought out and a well planned event. So congrats on initiating such events for emergency medicine, which is only going to improve the knowledge as well as interest on this specialty among our residents and beyond. And for today's session, I'm actually quite proud to be the first one in this series to deliver an actual talk in the clinical area. And thank you, Dr. Srinath, for inviting me over. So today's session is going to be on acute coronary syndrome, and this is specifically aimed at residents, and that to the first year residents, if you ask me, for those who are starting their emergency medicine career. I'm not going to be talking about anything fancy or advanced. We're going to keep it very, very simple. We're going to first look at what does ACS mean, what are the clinical features, and what are the differential diagnoses for ACS. How do we see the basic ECGs, managing ACS in the emergency department, and some of the complications which you should be aware of, and what are the last recent AHA guidelines in managing ACS in the ER. So we're going to be keeping it very, very simple. As Dr. Suresh mentioned, we got few more polls coming on your way. So please participate in those. And any Q&As you have, please feel free to type it in the chat box. During the session, I think some of the co-panelists will straight away answer your questions as well. We need not wait for the end of the session to get those answers. Right? So with this, let's quickly move on to understand ACS. Many of you may have heard this term during our MBBS days as stable angina, unstable angina, NSTEMI, and STEMI. But if you look at the recent nomenclatures, the stable angina is gone. We've got three broad nomenclatures which we need to be aware of. Unstable angina, non-ST elevation MI, and ST elevation MI. And sometimes these are referred to non-ST ACS, ST EACS. But more than the nomenclature, what is important for us is to actually understand the underlying pathophysiology behind it and where does it all lead to. Because these nomenclatures keep changing and keep evolving as the recent advancements in both interventional and non-interventional cardiology improves. But however, the basic concept or a pathophysiology is always going to remain same. As you can see from those pictures mentioned, the first picture is clearly your normal arterial lumen, right? Which is quite clear. It's got three layers, adventitia, media, and intima. And if you look at the second picture here, which I am pointing towards, you can clearly see a plaque developing, right? It's an atherosclerotic plaque. Why this develops and the reason we will see it in a little later. But as you can see, there is a plaque which is developing, which slowly increases in size. And at one point in time, there is a rupture and there is a platelet aggregation on the plaque, whereby there is a thrombus which is formed. And this thrombus will lead to partial or complete occlusion of the artery. So quite simply put, there is a plaque which slowly develops in size. At one point, it ruptures, leading to platelet aggregation, thrombus formation, and this thrombus leading to complete or partial occlusion of the blood vessel. Based on whichever stage of this progression of this atherosclerotic plaque, you kind of classify them into unstable angina, non-ST elevation MI, and ST elevation MI. We're going to be seeing that in detail in the forthcoming slides. But for now, understand this is the normal pattern of thrombus formation with regards to ACS. So now how do we define what we saw previously, right? What do we mean by unstable angina, right? An unprovoked or prolonged episode of chest pain, raising a suspicion of acute myocardial infarction without any definitive ECG or laboratory evidence. So these are basically patients who has got prolonged chest pain, but their ECG is negative, their troponins are also negative. So if you go back to our previous picture, so what does that refer to? That kind of refers to the first picture here, as you can see in the bottom, where there is a plaque rupture, but there is no thrombus formation yet, or there is no blockage yet, right? That's what it refers to. So this is unstable angina. There are symptoms, yes, but has it led to the block yet? Not yet. So how do we identify these blocks? It's basically using ECG and troponins, but that's not the case here. So let's look at the second part here, which is non-ST elevation MI, where clearly the symptoms are existing, which is your chest pain. And the ECG actually shows non-specific ECG changes like ST depression, T-wave inversion, or sometimes the ECG also could be normal. And here, the only difference is we are beginning to see the enzymes raising, the troponins, which are cardiac sensitive troponin. So here you have chest pain, normal ECG, but your enzymes are elevated. So that's what you call it as non-ST elevation myocardial infarction. So in terms of the occlusion, you can consider that as there is some degree of thrombus formation. It has not completely occluded your vessel yet. However, this is the beginning stage of a complete occlusion. You can confirm it or you can assume it as that way. And of course, the last definition is very, very clear. Acute myocardial infarction, where clearly there is symptoms and there are ECG changes now. Right? These ECG changes include acute ST elevation or new onset left bundle branch block. We're going to be seeing those changes in a little while. We're going to be talking about them. But for now, remember, once you have a complete near occlusion, then you definitely are beginning to see elevated troponins and ST changes as the muscle gets involved. Right? Just simply to keep unstable angina, non-ST elevation MI and ST elevation MI. Right? Only symptoms, symptoms, but ECG normal, drop positive is NST MI. Symptoms plus ECG changes also. Then definitely in these cases there is going to be ST elevation. So this is called ST elevation MI. Right. I'm going to introduce you to a couple of new terms here. And the reason I have put it up in these slides is as we go further, you will kind of see this entire definition evolve into something new. And that's the reason I want to sensitize you guys on this particular terminologies, which is occlusive myocardial infarction and non-occlusive myocardial infarction. Why these two terms are important is in few years from now, perhaps you will move away from those terminologies we just saw now into something like this. And what does this occlusive myocardial infarction basically means? Is an acute coronary occlusion or a near occlusion with insufficient collateral circulation where without an urgent catheterization and reperfusion, myocardium will undergo necrosis. Patients with OMI are the only ones who benefit from emergent reperfusion therapy. And these patients can present with or without ST elevation in ECG. So what this basically means is, going forward, we clearly know patients even with non-ST segment elevation MI or unstable angina. These were only definitions, but any occlusion, right, irrespective of symptoms, if there is a chance of this occlusion progressing, these patients, it's better to be considered for reperfusion therapy in terms of either an invasive procedure or non-invasive, because this will help avoid occlusion. The current thought practice is any ST segment elevation MI, which is STEMI, we will push them for urgent percutaneous intervention or reperfusion therapy using drugs. But as we go further, you might perhaps consider an urgent or perhaps emergent PCA for even non-ST segment elevation MIs, so that you don't want the occlusion to progress. But that we are not there yet today. So for now, as long as we remember this unstable angina against STEMI and STEMI, we are good enough. All right, let's look at the pathophysiology a little more deeper. It's quite straightforward. Why does this atherosclerotic plaque develops first? There is an epithelial injury. What is the reason for injury? There is a certain factors which can trigger these injuries. One example is like for smoking. I'm going to go through some of those risk factors. But once there is an epithelial injury, obviously there is a migration of monocytes and macrophages. Along with that, your low density lipoprotein LDL, which is considered one of the risk factors for cardiac diseases, also gets effused into your vessel layer and develops foam cells. And when there is collagen and proteoglycan deposits over it, eventually it forms a plaque. So that's how the mechanism of plaque is, right? So now you understand why your cholesterol control becomes important, because that's one of the significant factors in developing this atherosclerotic plaque if there is a epithelial injury. Right? So that's how the plaque basically gets developed. All right, let's quickly move on to the common symptoms. But before I explain these common symptoms to you all, please remember myocardial infarction, especially the non-ST elevation MI and ST elevation MIs, have got varied symptoms across different groups of people. For example, silent MIs are very, very common. Initial presentations with arrhythmias are extremely common, even cardiac arrest for that matter. So these symptoms which you have given are some of the common symptoms you might see with any patients in with acute coronary syndrome. But please remember, these are not the only symptoms of ACS, right? Okay, let's look at what are the top 4 common symptoms. Clearly, chest pain, and it's defined as a central chest pain, crushing in nature if you look at the textbooks. But most commonly, you may not see such classical chest pains in all the cases. Sometimes it could be simply a left arm pain It could be a jaw pain, even a neck pain, right? It not necessarily be a crushing central chest pain always, right? And it need not be even a chest pain many a times. But if it's a chest pain, please remember there are various types the chest pain can present. Clearly, there is nausea and sweating, profuse sweating, and difficulty in breathing, shortness of breath, right? So these are some of the common symptoms we notice. But always remember, it can present with various symptoms, GI symptoms, abdominal pain, no symptoms at all. So all these are quite common. So any patients who present to you, and also please remember, some of these symptoms can happen in isolation. For example, somebody can present only with shortness of breath, with almost minimal or no chest pain. Somebody can present with severe diaphoresis, sweating, with no other symptoms also. So please be aware of this. But for now, let's remember, anybody complaining of the above four, always rule out acute coronary syndrome, right? Okay. So this is again more theoretical than in practical utility in the emergency department, where what sort of a symptoms might occur during each stage of formation, right? But what we need to remember here is these are some of the definitions on how do we define a non-ST elevation MI and stable plaque versus unstable plaque. But I'm going to only focus there on uh, STEMI and sorry, I'm going to only focus on the NSTEMI and the STEMI part here on how the symptoms present. Clearly, these are symptoms even at rest, lasts clearly more than 20 minutes, and often accompanied by some of the symptoms which I just mentioned little while back, right? And usually not relieved by GTM, right? But again, all this need not be there for any patients. These are just more of a say a theoretical understanding of what's behind those pains and how it can present us. But always remember, in the emergency departments, these patients can present with varied symptoms. That's very, very important. So what causes this epithelial injury and why should the person develop a plaque in the first place? There are various factors for the same. Some are modifiable, some are non-modifiable. So the modifiable factors clearly includes behaviors like smoking, obesity, diet, lack of exercise, high serum LDL levels, hypertension, and diabetes. And non-modifiable clearly age, male are more prone to develop ACS, ethnicity, family history, and again, diabetes. So especially the Indian subcontinent or South Asian subcontinent, India, Bangladesh, Nepal. So we tend to currently kind of experience this epidemic of, I would say, non-communicable diseases. And cardiac diseases are extremely prevalent among our communities, even with young age group. So age as a factor here, especially when it comes to Indian population, you need to be very careful of, because acute coronary syndrome, myocardial infarction, if you ask me, is no more a issue or a problem of some elderly persons, which commonly we used to read in the book saying anybody above 65 years of age is at risk of MI, which is clearly not the case. Even young patients, especially male, even with around their 20s, kindly consider any chest pain. There is a differential diagnosis of ACS always, right? Always rule out ACS, even if it is an upper abdominal pain. Don't diagnose that as a simple gastritis. There is always a possibility of acute coronary syndrome. So please ensure that you screen all these patients and do not consider age as a significant criteria for ruling in or ruling out acute coronary syndrome. So that's a point which I wanted to drive. So could there be any differential diagnosis? There are a lot of differential diagnoses for chest pain. For example, even in cardiac, this could be a pericarditis, aortic dissection, and respiratory could be a pulmonary embolism, pneumothorax could be spontaneous or pneumonia, GI, which are most common mimickers, such as esophageal spasm, GERD, pancreatitis, even gastritis, and musculoskeletal, which is costochondritis and trauma. But please always remember, the first and foremost diagnosis with any chest pain patient is always going to be acute coronary syndrome. Unless you rule out ACS, you are not going to go into other differential diagnosis, especially the GI or the musculoskeletal diagnosis. You need to be extremely careful. So these are the diagnoses where of exclusion, not inclusion. That means basically you have excluded MI, pericarditis, angina, and severe respiratory issues. Then you can think of considering the GI or the musculoskeletal issues. These are not your exclusive first diagnosis most of the times. Just to keep things simple, what are the investigations you would prefer for somebody with ACS? Obviously, you're going to do a blood side ECG and cardiac enzyme levels along with your basic investigations. With chest X-ray is to rule out is there any other associated respiratory reason for chest pain, and your echo and angiogram or special tests, preferably by a cardiologist. So in ED, two core things for you to diagnose, clearly your ECG and then your troponins. And as we discussed earlier, unstable angina, symptoms, ECG normal, troponins normal. Non-ST elevation MI, symptoms, yes, ECG normal or maybe sometimes ST depressions, troponins are negative. And in case of ST elevation MI, clearly there is ECG changes in terms of new left bundle branch block or ST elevation. Okay. The Scarbosa criteria is given below. As you can see, 1 millimeter or more in limb leads or two contiguous limb leads or more than 2 millimeter in the chest leads. There are a few modified Scarbosa criteria also. But for now, let's keep it as any ST elevation in two or more anatomically contiguous leads, you consider that as an ST elevation myocardial infarction. Right? Okay, so what do I mean by this ST elevation? As you can see in the picture, perhaps you can focus on the picture in the bottom. We got a normal ECG or normal sinus rhythm here, PQRST waves, right? As you can see, in fact, the S kind of touches the baseline. And in other terms, we call this as a J point. J point is nothing but 0.04 in terms of the time. But in other terms, one small square away from your Q, that's your J point. If that gets elevated from your baseline, this is a typical J point elevation. You consider this as ST elevation MI. And if there is no elevation, rather if it is a depression from the baseline, you consider that as a ST depression. And if there is only an isolated T wave inversion, it could be a feature of non-ST elevation MI. So what were the features you can see? Normal ECG, J point elevation, ST depression, or T wave inversion. So these were clearly, this will signify some sort of an occlusion occurring for these patients, right? And the bottom ECG basically shows how it's going to look like in the future dates. But for us, what is most important is clearly the first four graphs on how a normal ECG, how an ST elevation looks like, and how an ST depression and T wave inversion looks like, is something that you all as EM residents should be confident of evaluating in the basic ECG. So let's look at the basic ECG itself. As you can see, the ECG has got technically 12 leads. This is a picture of you looking at a person from the anterior region, right? So this is basically a person's heart. You're going to place anterior chest slits in this zero axis. As you can see myself moving the arrow here. So your V1 to V6 leads or your anterior chest slits are technically placed in the front. Your left arm leads are basically your AVL and lead 1, which is going to look at the heart from the left lateral side. Your leads on the feet, which is 3 AVF and lead 2, is going to look at the inferior part of the heart. And your lead on the right hand is typically going to, AVR is going to look at the right side of the heart. Right? This is fairly easy to understand. You have V1 to V6 looking at the front of the heart. You have your left arm limbs looking at the left side of the heart. These are AVL and 1. You have the leads which are placed in the limbs, the 2-3 AVF looking at the inferior part of the heart. And you have the lead which you have placed in the right arm. This is AVR looking at the right side of the heart, or the right atrium specifically, right? So typically you're going to have 12 different leads. And I just mentioned, so inferiors are 2-3 AVF, AVL and 1 is lateral, V1 to V6 is anterior. And for you to look at the posterior, you've got two options. Either I can take my anterior limb leads, the V1 to V6, assuming I take this from the front and I put it in the back of the chest of the patient. That's one way I can assess the posterior, or other ways I can look for a mirror image of the posterior leads on the front. That's basically ST depressions in V1 to V3. So consider that as a mirror image of a posterior body. Right? Okay. So as simple as that. And we are given few arteries supplying each of those regions, right? So inferior is supplied by right coronary artery, lateral by left circumflex or left anterior descending, anterior by LAD, and posterior by either left circumflex or right coronary artery. Right? So based on wherever your elevation of the limb leads are, or sorry, elevation of the leads are, you're going to assume that particular artery is involved. And always remember, it's not necessary that it has to be only limited to, say, the main artery. It can go to circumflex. For example, LAD and circumflex can also get involved. So you need to understand that. Oh, how do you manage these patients? The ABCD approach of ER, very simple. Always manage airway, breathing, supplement oxygen, ensure you maintain saturation above 94%. Clearly have an IV access. You need not rush in fluids, as there is always a risk of heart failure in anterior wall MA. If it's an inferior wall MA, it's highly likely they might develop hypotension. It's always good to load them with fluids or keep a close watch. Measure heart rate and blood pressure. With inferior wall MAs, it's a high degree of chances of going into heart block. And if it's high blood pressure along with MA, you need to manage that before you go in for a fibrinolytic therapy. So we're going to be talking about it a little later. Measure sugar levels, sensorium, and E in terms of here is need not be as significant as an ABCD. So E basically expose the patient, but of course we're not going to be having any significant findings in this. So always remember ABCD approach. That will be better. Right. So how do you medically manage this patient? One, clearly pain relief. Morphine, there is always a concern that will it cause hypotension. So I would actually suggest you can supplement or replace that with fentanyl, which has got less severe effects on the blood pressure. So fentanyl about 100 mics is a good option. Always titrate oxygen as per need. Sublingual nitrates, and please vary of the blood pressure. So don't use that if there is a hypotension, inferior wall MA, you should be careful. And 300 milligrams of chewed aspirin, and if an antiemetic if necessary. If it's an unstable angina or non-ST elevation MA, we're going to consider a low molecular weight heparin, either enoxaparin or fondaparinux, along with clopidogrel, beta blockers, nitrates, and an elective angiogram. And this concept might change in the futures, but currently we consider elective angiogram for this patient, but that's more a decision of the cardiac team. So clearly, you all remember this MONA, which is most commonly known for morphine, oxygen, nitrates, and aspirin. So just remember this mnemonic MONA. That's a simple way to initiate treatment for these patients. The scoring system is basically to identify mortality rate and risk of future cardiac events. I would not put too much of emphasis on these such scoring systems, as emergency physicians, our primary responsibility is ensure you prevent the occlusive myocardial disease. As I mentioned before, how do I limit further occlusion by drugs or by fibrinolytics or by intervention? So the emergency medicine specialist has to focus on these three things rather than thinking about what would be the future implications of this current acute myocardial infarction. Obviously, it's going to be there, but our role or our responsibility is to manage or limit further occlusion from progressing. Right? That's what we are there for. And of course, if it is STEMI, clearly percutaneous coronary intervention and the door to balloon time is 90 minutes. You will also load the patient with clopidogrel 600 milligram. And if you have thrombolized the patients and if the patient has not shown reperfusion, a rescue PCA has to be carried out. It's one of the commonest procedures nowadays. In case if you don't have an immediate facility to do primary PCA for these patients. With regards to thrombolysis, if you are not a center with invasive cardiology option, you can think about lysing these patients using either altiplase or tenecteplase. Streptokinase has got extremely low efficacy, and if you ask me personally, I would suggest not to prefer streptokinase anymore for thrombolysis, as it has got very high chances of failure rate along with complications rather than success rates. Okay. There are a few contraindications for fibrinolytic therapy, so we're going to be seeing that in the forthcoming slides. So these are some of the long-term managements. You wouldn't worry about it too much, as this is after you have managed these patients in ED, and once the patient undergoes some sort of a reperfusion therapy, these things will come into play. So for now, I'm not going to be focusing on this. This is slightly important. Clearly, there are early complications and late complications. And what we need to be aware of in the emergency department is all these patients are connected to monitor, because clearly the chances of arrhythmias are very, very high. So always connect your cardiac ACS patients to a defibrillator monitor rather than your routine monitors. You ensure that you transfer these patients within the hospital, even on the way to the cath lab, they go attached to a defibrillator. That's one. A high degree of chance of developing cardiogenic shock, hypotension. So that's one thing you need to be wary of, especially in terms of inferior wall MA. Ensure you manage the hypovolemic shock. Cardiogenic shock is because of pump failure. If there is a heart failure, fluid overload, you should be extremely careful about managing or giving fluids. So don't rush in or don't pump in too much of fluids for the patients. Don't rush in for fluids. Ventricular arrhythmias, VFs and VTs are very, very common. So make sure you manage VT. In case if there is a VT with pulse, you know what is the protocol to follow. I'm not going into the detail for it, but these were some of the common complications which can happen in the emergency department, right? So cardiac arrest is very, very common. So keep a close watch. Somebody always accompanies this patient. There is a continuous close monitoring. Preferably, these patients are kept closer to the area where there is a continuous nurse or a doctor monitoring these patients. So just remember that. So let's quickly go through some of the protocols. I got last one or two more slides to cover. And this is your EHA algorithm of managing chest pain patients. We have covered most of it in our slides. So as you can see, ST elevation MA, start adjunctive therapies. Do not delay reperfusion, right? The reperfusion here can be either through drugs or through PCI. So if it's an ST elevation MA, primary focus is to reperfuse, because the more you delay, the more cardiac muscle is going to die. So the door to balloon time is 90 minutes. And for fibrinolysis, door to needle is 30 minutes. So just remember these 2 points. Door to balloon is 90 and door to needle is 30 minutes. That's very important. So other than that, so pretty much the protocol we have covered in the previous slides. So this is your fibrinolytic checklist. So if you're going to be using fibrinolysis, please ensure that there is absolute contraindications, and there are certain high risk patients you should be aware of. So some of those contraindications include systolic blood pressure higher than 200 milligram mercury, diastolic more than 100. And the difference between left and right arm systolic blood pressure, this kind of signifies that could be a possibility of right aneurysm. So you need to be careful about it. And few other issues like history of structural central nervous disease, significant head injury, closed head injury, recent stroke or recent major trauma, recent surgery, any history of intracranial hemorrhage, bleeding, clotting problems, or those who are on blood thinners, pregnancy, and any advanced cancer or severe illnesses. So there are certain absolute contraindications in this, which you will know, and there are relative contraindications. The bleeding risk clearly with, say, fibrinolysis is definitely more than the PCA. So you need to be preferring these patients for percutaneous intervention at the earliest. So I think with this, let me quickly stop. And just quickly to summarize on what we covered today, please ensure do not waste time whenever you are dealing with a case of acute coronary syndrome. What's most important is your ED diagnosis. Don't get carried away with symptoms and assume that the symptoms are going to be only chest pain, sweating. No, you will get varied types of symptoms. Time is key here. Start with your medical management. Remember MONA. Once you have managed your pain, aspirin, clopidogrel, look at how fast you can provide a reperfusion for these patients, either through chemical methods or through intervention. I think with that, we will stop. And thank you all once again for joining today. We got few more polls, but I'll take that once I pass it on to Suresh.
That was an excellent presentation. I think we have covered it all, including the assessment, which include the initial assessment as well as the diagnostic assessment, and how to come to the diagnosis, which we are not going to miss in the emergency department by any emergency resident as well as any emergency physician. And what is the management plan, and a couple of scoring systems were mentioned. I think we have covered it all. And thanks to, I think we have the new words also, OMI and NOMI. I think those are also, I think we should be aware, along with the TIMI scoring system as well as the GRACE scoring system. So one thing is, every time we say, if someone comes with a chest pain overnight or in the late hours, never discharge patient. That was, they need the serial ECGs as well as the biomarkers to be evaluated before discharging the patient. So late night, again, I think it's not safe. But of course, anytime it's not safe, but especially when they come in the early hours as well as the late night, never dispose any chest pain patient from the ED. Rather, you can keep that patient in the ops bay or observation bay if you have. Otherwise, you can keep in minors as well, till you get the correct diagnosis, and then I think that would be the action plan. Over to Naveen to add anything, or to the Dr. Ranjith or Dr. Varma here. I think if you're okay, I think we can proceed for the poll. Uh,
Yeah, I think let's quickly launch the poll. So let's see what the attendees have to say.
yes. And everyone, you're invited to post your questions in the Q&A or chat section. We are ready to answer. This is an open scenario wherein you can just ask us anything. I mean, post this poll, we can answer your doubts if anything are posted in the chat box. Yeah, I think we can go proceed to the poll. Dr. Saravana.
Suresh, can you see the poll questions? I have
Yes,
posted
we
already.
can see. Yes, yes.
Yes. Are you able to answer? Because I'm not seeing people answering it.
So all of you, you can just answer. I think first question, I think all of you know. Rather, if you're not answering, we'll proceed for the discussion. It's a single choice answer, out of which four options were there in the for the first question. In which of the following is not classified as acute coronary syndrome? You're allowed to participate in the poll, and you can answer.
Suresh, can you just try whether you are able to answer the poll question?
The thing is, permission we haven't got.
They can answer, but once they answer all the 5 questions, then only you will see the results.
Okay, all right, thank you. Because I'm not seeing the graph moving, so that's all right. Thank you. So we will give them perhaps 1 more minute.
Yes.
Yeah.
Yes.
We'll give them 1 more minute. I've seen about 15 people who have answered so far.
I think we can allow a few more minutes. I think,
yes.
how the participants are answering for all the questions. Yes.
Okay, we can continue, I guess.
So we got 31 answers. I think we'll give them one more minute, no? Last minute.
Yeah, I think, yeah, we can give yes. I think 31 out of 42, 75%, I think.
Yes. Okay. I think let's end the poll now. It's 5 minutes. So there you go. So which of the following is not classified as an acute coronary syndrome? Atherosclerosis is basically a pathophysiology behind formation of this plaque. So that is not a part of ACS. Unstable angina, non-ST elevation MI and ST elevation MI. These three are currently under the ACS classification. I think most of them have got that right. Very good. The second question is basically on an acute coronary syndrome with total occlusion is most consistent with ST elevation. As you can remember the picture, that near total occlusion will actually result in a clear ECG changes. Okay. Good. Which of the following is a not correct recommendation prior to patient's arrival to the hospital? I think there's got mixed answers here, so quite interesting. I think the right answer here is clearly patients are not advised to wait at home in any case, right? The reason we have put this up question is it is not uncommon for us to be asked by a patient relative, sometimes over a phone call or even by patients themselves, saying, could this be gastritis or is there any recommendations where I can manage myself at home, or doctor, can I wait until I come tomorrow morning? Or even these ED patients who come to the hospital who say, can I go and come back in the morning if it continues? Because you might recommend few ECGs and investigations. They might say, I think it could be gastritis. Can I come back tomorrow morning? Those are the things which you cannot accept at all. So anything which is pain, you cannot allow them to wait at home for symptoms to subside. It is better to evaluate. I think that's the point we need to remember. And the next one is an interesting question, which is an absolute contraindication for fibrinolytic. I'm glad to see most of them have picked up the right answer. If there is any current use of anticoagulants, be very careful. That's one of the key history points when you manage these patients, you need to understand and take. And in that case, you need to get in touch with your cardiac team for next steps of action. Which are the typical clinical presentations of ACS? I guess since a single choice is given, you all picked angina, but it's clearly angina, diaphoresis, shortness of breath, nausea, vomiting. Perhaps every single symptoms you say there in the list is all correct, right? And we can still add another 20 more symptoms to it. Or even if you say none of the above, it could be still an ST elevation MI, you are still correct, right? So you need to be very careful. So please remember, do not just get carried away with the chest pain as a sole symptom of MI. So that's a very important learning for all of us. Thanks, Suresh. I'm stopping the poll for now.
So I think good to see the participation in the polls, and congratulations for the correct answers. That means you're going to save lives as we usually do on a daily basis. So once again, we are very thankful for Dr. Saravana for being for part of the sessions and for your time for this session. I'm looking forward to see you all later. And please remember, every Friday we are bringing a current and the latest trending updates in the field of emergency medicine as well as acute medicine. Please, if you miss out this Zoom session, you can go to the Yashoda Hospitals FB page and you can just see the session again and again, which was appropriately and excellently delivered by Dr. Saravana. And thanks to all, including Dr. Naveen, who organized this event very well, as well as our Dr. Ranjith, as well as Dr. Kiran Kumar. And looking forward to see you all again. Okay, thank you.
Thank you all very much. Have a very good
evening. Thank you, Dr. Saravana. Thank you, Dr. Suresh. Thank you, Naveen. Thank you, Ranjith and Kiran.
Thank you, Dr. Srinath. So thank you all.